All right, everyone. I heard your requests on my season 2 finale reaction for The Pitt. I got a lot of you asking if I could go back and watch the old episodes of The Pitt. And I thought, I could maybe go and do some of the episodes that I know had stronger psychological themes, or I could go back and do all of them. And then I realized, why would I pass up an opportunity to watch one of my favorite shows from the start again? So that's what I'm going to do. We're starting with season 1, episode 1. And if you're new here, my name is Dr. Robert Duff. I am a clinical psychologist, and more specifically, I'm a neuropsychologist. So my expertise sort of blends neurology and psychology. So in a hospital setting, sometimes I have a little bit more to say about things like neurological disorders. But I've watched The Pitt in its entirety. I have not gone back and rewatched The Pitt, though. So these season 1 episodes, I'm going to remember broadly what happens, but a lot of the details I probably don't quite remember. So it should be interesting to go through it again. I'm going to address things from a psychological lens, from a neuropsychological lens, and let's see what we get into. So here we go. Season 1, episode 1 of The Pitt. Just as a point for the show itself, I know that they intentionally do not use a soundtrack for the show. And this here is an exception leading into it. And I think that's pretty interesting because he takes off the headphones as soon as he enters the hospital. And what we get is the ambient sounds of the hospital. So that really brings you into the space and just the mindset of being in the hospital setting.
Your last name?
It's J.A.
Gloria is looking for you.
No guts, no Gloria. Must be time for my weekly spanking.
It'd be nice for all our sakes. You sure you're cool being here today?
Yeah, why wouldn't I be?
Well, if you need to talk.
Yeah, I won't, but thanks.
So that's a pretty clear encapsulation of Robbie's character throughout the entire season and the next one. If I recall correctly, this is the anniversary of his mentor's death, which is why he looked up at the picture of him on the way in. And, do you want to talk about it? Not gonna. Okay, here we go. And then we see the hospital board here, which has some really interesting stuff. It has the MD that's on for the particular patient, the issue, the RN that's there, any of the labs, radiology, EKG readings, medications, and comments. So we see some various stuff like Zofran, so, for stomach upset, for vomiting. Let's see, hyperemesis. So again, throwing up a lot, hyperkalemia, high potassium, waiting dialysis. What else? Waiting discharge, waiting family, possible peds admit. So that's very realistic as to what I've seen in hospitals. The bottom one repeats Zyprexa. So Zyprexa is a mental health medication, a psychiatric medication. So that's interesting. And it says MD Psych. So yeah. Altered. We'll see how many of these we end up seeing in the episode itself.
Where's Abbott?
Getting some air?
Morning, Jack.
What are you doing here?
I'm working. And you?
Oh, I don't know. Had a guy come in, hit by a drunk driver in a crosswalk, 39-year-old vet. Survived 3 tours without a scratch. I spent the last 2 hours coding him.
That's always a rough way to end the night.
Must have had a reason at one time to keep coming back, but I can't think of it right now.
Because this is the job that keeps on giving. Nightmares, ulcers, suicidal tendencies.
Wow. Seeing this now in retrospect after seeing the finale, it's a very sort of full circle. I kind of forgot about this. If you haven't seen the finale, I'm not going to spoil it here, but there is sort of kind of a full circle element to it with the two of them in this discussion. And yeah, I mean, the emergency department is no joke, and it has one of the highest rates of burnout among all medical professions, probably all professions, for very good reason, right? You can be the most psychologically resilient person. You can have good mental defenses in place, but it's a combination of the horrors that you see in the job and the job itself, right? Like one of the things that you try to do when you have a job where you see a lot of trauma or you deal with very, very serious things, it's high stress, is you try to balance that out, right? You try to balance it out with a support network, with, you know, what you might call self-care, whatever it is to you that helps maintain your mental health. But as an ED physician, you may not actually have a lot of time for those things. You try to make it, but it's a challenge. And so, yeah, it's a very, very difficult job, and the rates of mental illness are off the charts for this profession.
Besides, if you jump on my shift, that's just rude, man.
Hope I'm never one of your patients.
That makes two of us, my friend.
I got a pregnant teen coming back today for mifepristone and a small bowel obstruction waiting on surgery for the last 3 hours. Oh, and unfortunately, the Kraken is still boarding in BH.
Still? Guy's been here for a week waiting on a psych bed.
Yep, he's only getting worse.
So this is a psych patient they're talking about. That's probably the one that had the Zyprexa on there as a repeated medication. Unfortunately, nicknames like that, they do happen, especially in, non-psychiatric places, even psychiatric hospitals. But, the Kraken, the Karen, the this, the that. It's not the most respectful way to talk about somebody, especially if they're dealing with mental illness. But it is something that does happen.
Catching some Zyprexa disease at the moment, but when he wakes up, God help you all.
So Zyprexa disease. So Zyprexa is an atypical antipsychotic called olanzapine. So it's a medication that's used to help with people who are experiencing psychosis, delusions, or hallucinations. It's also very commonly given as an adjunct treatment to other mental health disorders, like, say, severe depression. And it is something that can help with agitation. So the Zyprexa disease means he's chill, maybe he's asleep, but as soon as that wears off, then that agitation and potentially aggression will reoccur.
My second husband, Everett, in 1964, he unfortunately passed in 1976 from a heart attack while we were vacationing in Kissimmee, Florida. It was awful.
Good morning. We're gonna round Dr. Mohan.
Excuse me, Estelle. I'll be right back.
I know that one of the things Dr. Mohan tries to focus on is individual patient care, taking the time to hear people out, letting them expand, which is amazing. There's tension between the two of them because Dr. Robbie is often like, let's go. This is the ED. We need to keep things moving. But especially when working with elderly people, which I do a lot, you get better results often when you do take that time rather than rushing and redoing and rushing and redoing.
Track every resident's patient scene per hour.
I was just taking her
It's a
history.
brief backstory about what brought them in, not an autobiography.
I was almost done.
You hadn't even made it to this century.
Patients, they check in for registration here.
Another note about that. I mean, one of the things that I hear from patients of mine very often, not even from emergency room doctors, but from, say, their neurologist, say from their primary care physician or any other specialist, is that it's in and out. Psychiatry, that's a common one as well, right? It's in and out. They're talked to very briefly, and then there are details that are missing. I'm often inheriting records from other providers where I notice things that I'm like, say chronic kidney disease. Is that something that you actually have? And they're like, no. Or I see something else that in the chart that seems a little bit off, and it's just something they misheard or was incorrect because they are rushing so quickly. So luckily in my job, I get to spend hours with people, right? I get to spend an hour or more if I need to doing a thorough clinical interview. That's not the ED, but you can always take a little bit more time, I think. And it's an approach that can lead to better outcomes in the end.
What's going on, Sherry?
I burned my hand on a sterno.
What are you doing with the sterno?
Cooking.
You were cooking with the sterno?
We were making s'mores.
Sweet. My son loves s'mores.
We've been here for hours, and I have to get them to school. Do you know how much longer this will take?
Yeah. Let's see. You taking anything for the pain?
Not yet.
1,000 of Tylenol, 400 ibuprofen, and the saline dressing?
Yes, please.
Okay, we're going around.
And the fun begins. All right, Sherry, we're gonna patch you up and get you out of here as soon as possible, okay? I'll be back.
Dr. McKay is always great as somebody who's very empathetic. She uses a lot of self-disclosure, which is a tool. Obviously, you know what self-disclosure means, talking about yourself, but it's considered a tool in psychology and medicine that can be used to, build rapport with somebody, to enable them to disclose more and build trust. It's not always appropriate. Some doctors, talk about themselves way too much and it makes the patient uncomfortable, or there's no reason behind it. So, what I like to think about is when thinking about doing a self-disclosure, whether it's big or small, what's the intention behind it? Is it because I just want to chat? Is it because that's going to help in some sort of way? Is it because it might teach something to the patient that would be helpful? You just need to think about that stuff.
And we all know Louis Cloverfield. Blood alcohol of 420 at 11 p.m.
I've been cutting back.
How is he still breathing?
That's a lethal dose for you and me. That's happy hour for Louis.
Sobered up, had 2 rounds of lorazepam.
Hold out your hands for me, Louis. Another 2 lorazepam.
On it. And a script for Librium.
It's good to see you, Louis.
It's always a pleasure, Doc.
So with Louis, who is a character that repeats many times, severe alcoholism. And one of the things you have to worry about when you're detoxing from alcohol is seizures or delirium tremens. So lorazepam is a benzodiazepine, a medication that's often used for panic attacks or for reducing, seizure activity. And that's what they're talking about in that scene. Very common to have some, what you call like frequent flyers in the emergency department or in many other settings as well. And Louis is a great character.
Okay, here we go. Ready? 1, 2, 3.
Good breath sounds bilaterally, but we need to protect his...
Apparently, he jumped down to save the lady. When he climbed back up, he slipped, fell back, and hit his head.
Thanks.
It's more of an R2 procedure. Mel, right? I need you on the E fast. Pupils, 4 millimeters, and reactive.
Okay, that's encouraging.
What do you want for meds? 120 ketamine, 80 of rock.
So doing a lot of different things at once. The people's reactive, they're looking at neurological signs. So is there severe brain injury that might be causing the pupils to be unreactive or not bilaterally reactive?
Tip on a monitor.
Morrison's clear.
That's a lot more blood than expected.
He's probably anticoagulated for AFib. Check his medical record, see if he's on a DOAC. Standby with 4-factor PCC if there's a brain bleed.
Anticoagulation, meaning stopping the blood from clotting. If somebody has, atrial fibrillation or other cardiovascular issues, they may be on these medications. That does cause a higher risk of bleeding in the brain, as she mentioned. So if there's a head injury, and even chronically over time, what we call microvascular disease, where the brain kind of just breaks down in the vasculature over time. It can be a part of normal aging, but for people with anticoagulation, it can be more extensive. And that's kind of what they're talking about here with the brain injury, potential brain bleed that they're trying to rule out.
What's in the PCC? No.
Clotting factors 2, 7, 9, and 10.
Okay, be right back.
Hit the offend, didn't touch her.
Did she faint or did she trip off the platform?
Nobody knows.
What might have made her faint on the platform?
Could be an arrhythmia, cardiac event.
So she needs
EKG and a troponin.
Okay, good.
What could have made her faint? TIA, transient ischemic attack, CVA, cerebral vascular event, or cerebral vascular accident, rather. So that would be like a stroke. So they want to get a MRI. Usually they end up doing a CT scan in the hospital. Maybe that's what she said. CT is a little bit quicker. It's a little bit less detailed than an MRI, but that's usually the first line when you're in an emergency department.
Can we please push the morphine?
No, it could cloud her mental status.
I can't do an exam like this. Push the damn morphine.
We're doing a popliteal block. Numbs the lower leg, no side effects.
Wonderful. Where's the other guy?
Next door. He's a bit worse.
Pan scanner, let me know when she stops screaming.
So she wants pain management so she can do her, I think, orthopedic exam, or is an orthopedic surgeon maybe? I can't exactly remember, but she wants the pain to be under control so she could do her examination. other doctors saying we can't use the morphine because that will cloud her mental status, because that would make it so that she can't think clearly. They can't do a proper, neurological exam. So the doctor suggests, do a block rather than the morphine. So you're not going to have the cognitive side effects, but you'll still have the pain management.
Good Samaritan dude has a small left temporal intraparenchymal bleed.
Small left temporal interparenchymal bleed. So that's basically just saying left temporal, so left side of your head, temporal lobe. Interparenchymal just means within the tissue of the brain. So a small brain bleed.
No epidural, no subdural, no midline shift in the brain.
That's good.
No midline shift means nothing is swelling to the point that's pushing the brain to the side. No subdural, meaning, the beneath the dura mater, so beneath the tissue that connects your brain to your skull. So nothing between the skull and the brain, nothing epidural, so nothing inside the dura, which is all good. So just kind of a small brain bleed, which is not great, but it's better than it could be.
You can recover. CT can take her in 5. Let's have a look. Bandage scissors.
All right.
I forgot about that. Yeah. So some people do faint at the sight of blood. There's a term, blood injury injection phobia, which often for people is not exactly a phobia like the other phobias where it's an intense fear reaction. It's more of a vasovagal response. So there's a fainting response. And there's actually a technique that is taught called applied tension, where they actually teach you to flex your kind of chest and your trunk muscles, release them, flex them, release them, to force your blood pressure up. Because what happens is your blood pressure drops and that causes the fainting. So people with this reaction can actually learn to, compensate for it. But yeah, it's a pretty common thing. Definitely a challenge if you're going to be in an emergency department with these really, really nasty injuries.
Med student down.
So what's the plan?
ICU when we can get a bed and admit for supportive care.
They said it was a left temporal lobe bleed. That was the right side of his head that they were stitching up. It can be the case that you get what are called coup contra coup injuries, where if you hit your head, the brain bounces back and forth and it'll hit the other side of your skull. I wonder if that's just a continuity error.
Repeat head CT in 3 hours or sooner if he blows a pupil.
Want a Keprolilla?
Order's already in. Nice job.
Do you think he'll wake up?
Maybe. Maybe not.
Am I gonna be okay?
Yeah, you just need to take it easy on yourself. Muscle breakdown and myoglobin damaged your kidneys.
Why'd you shock my heart?
When your kidneys don't work, potassium builds up and messes with the electrical activity in your heart.
She's great at explaining things to the patients in a comprehensible way, right? Like, instead of using a lot of technical terminology, she said messes, with your heart, and not shying away from the actual details, but explaining it in a way that's comprehensible, I find is very, very helpful.
Can it happen again?
We gave you medicine to lower your potassium, and you'll need dialysis to clear it all out.
Then I'll be okay.
Yeah. You might need a week or 2 for your kidneys to recover, but yeah. You really need to hydrate like crazy before and after a triathlon.
Trust me, I won't let this happen again.
She's gonna miss the morning arrival of the living dead.
How many are we expecting?
We're getting 3, but 1 died en route. Don't know who's luckier, us or them.
What's open?
14.
89-year-old woman from a SNF. History of emphysema, CHF, MS, VFib, unresponsive to 3 shocks, 2 rounds of epi.
A lot of that was talking about her status, but they said SNF, that means skilled nursing facility. She's under a continuous chest compression machine there too.
What is that?
Lucas chest compression system.
Robotic CPR. Everybody get a hold? 1, 2, 3.
Students are dropping like flies.
Take a break, ice the finger.
You can count on getting a couple elderly patients every day around 7:30 after the nursing homes and assisted living facilities do their morning bed checks. You can practically set your watch.
Was there an advance directive?
No, full code for the nursing home.
Seriously,
Lucas off.
Still VFib.
Lucas on. One more round of epi, one more shock, and then we call it.
Joseph Spencer, 79, fever and cough from assisted living. He has a history of mild Alzheimer's.
So a history of mild Alzheimer's would mean that he has short-term memory loss. So things that have happened recently, his brain does not want to encode into his memory, primarily because of atrophy in the temporal lobes, which includes the hippocampus, which is the structure in your brain that consolidates your memories. So he's going to have, reduced memory for things that have happened recently, trouble recalling conversations he's had, recent events, and then also probably some difficulty with minor aphasia. So some trouble finding the right words, trouble expressing himself appropriately, sometimes trouble understanding exactly what's being said to him. But he's in the mild stages, according to them. So that means that he probably does not have, really, really long-term memory loss, forgetting his family members, getting confused about who he is and things of that sort. At least that's what's typical for early Alzheimer's.
1, 2, 3.
Heart rate 130, BP 90 over 60. You gave him 500 cc's normal saline.
Hi, Mr. Spencer. I'm Dr. King. This is Dr. Collins. How are you feeling today?
Is it dinner time? I'm not really hungry.
Do we have any paperwork from the facility?
He has a pulse. IV fluids and medications are fine, but no intubation and no chest compressions.
So for these elderly patients, they're always asking about what the healthcare directive is, what the plan is. So there may be people who are able to get every intervention, others who they're only allowed to do certain things with, and otherwise they're going to let them pass naturally, essentially. For him to be asking, is it dinner time? That would be unusual for early Alzheimer's. But of course, you're not looking at just Alzheimer's. You're looking at Alzheimer's plus whatever's happening to him. So there's a lot of different things that can cause, say, a state of delirium where things are elevated, or medical issues may cause additional confusion. And taking somebody with Alzheimer's out of their normal routine, normal place can often elevate things as well.
Charging and...
Stop. Call it. Nursing home just faxed us a DNR.
DNR, do not resuscitate.
Kidding.
Power out the defibrillator and the Lucas.
Complete waste of time and money. Who the hell works at that place?
A nurse taking care of 60 patients who couldn't find the form.
She called 911 so she could take care of the others.
Okay, let's move her to the viewing room and notify the family.
Yeah.
I mean, that's no joke. I go into skilled nursing facilities and assisted livings all the time to evaluate people. Yeah, I mean, they're understaffed, underpaid, doing the best they can with people who are usually not happy that they're trying to take care of them, right? The residents themselves, the patients they have, often very combative, agitated, all these sorts of things. So it's another job where there's a really high burnout rate and a lot of turnover, a lot more turnover probably because, it's harder to have the hiring process and all that for a doctor in an emergency department. But, nurses and other helping professionals within skilled nursing facilities, there is a high turnover rate.
I'm so sorry, ma'am. We don't understand you.
Honestly, at this point, it's not standard protocol, but I would pull up a map on my phone, be like, where are you from? Like, there are other things I think they could be doing here. Language services they tried using, but it didn't work out. You got to kind of go beyond the standard protocol a little bit in a situation like this. And so, can you write? Can you point on a map where you're from? At this point, are there AI tools that could be used to identify the language? Things like that.
Me? I'm Dr. Heather Collins. I'm from here, Portland, Oregon.
I swear to God, I did not remember that they did this. I have seen this back when it was first released, but I did not remember this.
Begin. You. Where are you from? China? India? I can't tell where you're pointing. Tajikistan? Nepal. You're from Nepal.
Nepali.
I'm just surprised it kind of took that long, honestly. Seems like a pretty good strategy to me.
When did the vomiting begin?
Last night.
Do you have any dizziness or fatigue?
looking at the board at the beginning, there was a hyperemesis. I wonder if that was her, but she was on there, too early. It was like out of order for like the story editing, or if there was somebody else with that was there already.
Is that bad? Can cause heart problems, but we're gonna correct it. Okay, 10 in the bag, 20 PO. Johnny, any questions?
David, have you two traveled out of the country recently?
No, we never go anywhere. Is she gonna have to stay here?
If the rest of the tests are good and she responds to treatment, she can go home.
So in a situation like this, you're always like trying to pick up context clues. Some of the questions you ask are directly related to the patient's care. Others are sort of just observing interactions between people. So at this point, they can pick up on like something's a little odd between them. Like he brought her in, he's answering the questions. It's not like, there's not signs of like overt abuse or something like that, but there's something that's a little bit off. So they're trying to understand that situation better.
Mr. Milton, my name is Dennis Whitaker. I'm one of the student doctors here. I'll be seeing you first.
Nice to meet you.
BP's 150/90.
Okay, that's just a touch high.
I forgot to take my damn enalapril this morning.
No, we'll get that for you.
Tell me about this belly pain.
Great open-ended question. Instead of saying, so you're having belly pain, right? And that's like a yes or no question. Tell me about this belly pain, right? Open-ended, more of a prompt than a question, but it gives him room to expand, and you're going to get more information that way.
Started about here. Woke me up at like 2 a.m. Pretty intense. Lasted about an hour.
I need a fresh set of eyes.
On what?
54-year-old woman brought in with intractable vomiting by her 18-year-old son. I'm getting a weird vibe.
A weird vibe, right? And when you're a clinician, you don't overinterpret weird vibes, but you don't ignore them either.
How so?
I don't know, maybe she was given something, some sort of elder abuse. It's just a strange dynamic I can't quite figure out, and you're really good at sussing out that sort of thing.
I don't know about that.
And I've had that before too. I've had other people in my clinic, not in the ER, but like in my private practice, other doctors be like, hey, pull me in from the other room, be like, hey, do you want to get in some eyes on this? And just sort of like talking with them and just getting another set of eyes on the situation to see if I get a similar vibe that they had.
Any chance he could have gotten into some bath beads or laundry pods?
No, and there's no such thing in our house.
What about gummies?
No, we're very strict about candy. Right?
Oh, shit. Danny.
What about Danny?
Your brother, he gave me some gummies he got in Cleveland. They were in my coat pocket.
Are you fucking serious?
Pot gummies?
Yes. I'm so sorry.
Let me call the lab. Maybe the tox screen is back. Hey, this is Dr. Langdon from the ED. Can I fast track a lab on a little boy, last name Jones, first name Tyler, tox screen?
Walk out, I mean it.
Why don't we step outside and maybe you can help me figure out how much he may have taken?
So in a situation like this, separating, getting a little bit more control of the situation is often called for. I have situations like this a lot when I'm doing home visits where I might need to have, say, assistant that I bring with me, go with one of the partners, like the husband or wife, go take them on a walk, go look at their awards or their pickleball or whatever, while I talk to the other person to avoid agitation and fighting. And then maybe we switch off later, things like that. And so this is a good move from Langdon.
Thanks. I appreciate that quick turnaround. Labs confirm it. Your son tested positive for cannabis.
This is a fucking nightmare.
Teresa. David, this is my attending, Dr. Rabinovich.
Hi, Dr. Robbie. We need to do a pelvic exam. And David, I don't think you want to be in here for that.
Definitely not.
Can you have Nurse Perla come join me, please?
You want a coffee or a soda?
So another way of, separating out, kind of controlling the environment, getting eyes on someone specifically, separating them so there's not, conflict or somebody speaking for somebody else, undue influence, things like that.
Or something?
Why do I need a pelvic exam?
You don't. Your son seems like a nice kid. He's clearly worried about you. But your exam and your labs are not matching any of the usual diagnoses, so I'm not really sure what's going on.
I'm not here for me. I'm here for David.
I don't understand. He said that you've had persistent vomiting, some
I made myself
dehydration.
sick with Ipecac.
To induce vomiting? Why would you do that?
So David would bring me here. My son has some problems. He needs professional help.
Okay, what kind of problems? Drugs, alcohol?
I found some of his writing. I thought it was schoolwork, but it wasn't. It was lists of girls he wanted to hurt.
I forgot about that. Shit. So in California, in the U.S., there is a code 5150, which is danger to self or danger to others. There's also something called Tarasoff, which is a duty to warn. And so if you can, suss out that there is a reasonable suspicion that somebody is planning to hurt somebody else and there is an identifiable victim, you do actually have a duty to warn that person if you're able to, and also to inform law enforcement. And failure to do so can have serious consequences.
Hurt them how?
He said they should all be eliminated.
Has David seen a therapist?
No. He's not a bad kid, but I'm afraid he's troubled. And I didn't want to call the police because I was afraid they'd overreact. He's just a kid.
How old is David?
He just turned 18 last month.
Then he's considered an adult, and he would have to consent to treatment. Do you have any guns in the house?
No. My husband did, but I got rid of all of them after he passed.
So what Robbie is doing is identifying, is there a means? Is there an intention, right? So saying something vague like they should be eliminated, that's one thing. You have to evaluate how serious that threat actually is and whether there's actually a reasonable way that it might be carried out. And there's just more that you need to know about this before acting immediately.
He's a good soul. I just don't want to see him hurt anyone or himself.
I got a situation. 18-year-old kid brings in his dehydrated mom. Dad died during the pandemic. Mom's vomiting is self-induced for the sole purpose of getting him here after she finds his death list for classmates.
Okay.
Yeah, that would be my exact response to that, or like, oh, fuck.
What does she want us to do?
Help him, protect him, save him.
Where is he now?
Talking to McKay.
How are you doing?
Me? I'm good. I'm always good. You know that.
Do I? Does anybody?
I'm an open book.
Not even close. You do know you can always come talk to me,
Yep.
right?
How's it going over here?
Good, good. We're just going over aftercare instructions, prescription medications, special diet for the next few days.
Dr. McKay, can you check orthostatic on Mom?
I can.
David, I wanted you to meet Kiara. She's a social worker here who helps in situations like this. We heard about your father's passing. We're really sorry. And we know that can put a lot of pressure on somebody your age, which combined with school and now having to take care of your mom.
Only criticism of this right now, this would not be happening there. That would not be happening in the middle of the, ER. They'd pull him somewhere because now they're getting into HIPAA territory.
That's a lot.
It's fine.
We just want to make sure that when your mom goes home, you can handle it. We want to make sure you have someone you can talk to if you need to.
I'm okay. I don't need to talk to anybody.
After a parent dies, the sadness can last a long time. How's that going for you?
It's not a problem.
What about school?
What about it?
Anything you enjoy there?
Not really.
A lot of people have thoughts that can disturb them. If you've had any, it's okay to talk about.
What does that have to do with my mom? Is she gonna be okay?
Yeah, she's gonna be fine. She's probably got a stomach virus, maybe food poisoning. I think she's more worried about you.
She always worries about me.
Does she have a reason to?
No. It's almost 8. I gotta go.
Sure you wouldn't prefer to wait with your mom?
I'm late for school. She can just call me when she's ready.
It would actually be kind of helpful to talk to you some more. Hey, David. David. Hey, just give me 5 minutes. Leave me alone. Hey, David! Shit.
Robbie! Robbie! Got a college kid, respiratory arrest, coming in hot.
So yeah, I mean, in that particular instance, he wasn't able to fully evaluate, and the social worker wasn't able to fully evaluate. So then the question is, you know, you weren't able to rule out risk. So what do you do? Never stops though.
Robbie, we need to intubate here.
Dr. Adamson just went down with a pulse ox of 65.
So we're getting a flashback now to, you know, what probably 2020 COVID time when his mentor was, you know, about to die. And so we see like the COVID protocols there, and it's pretty common for people with PTSD or other traumatic reactions to have full flashbacks where they kind of feel like they're re-experiencing the traumatic event again. And that can be triggered by sensory stimuli that are similar. And so walking through that waiting room after having just run, so his heart rate is up, he's going through the waiting room and it's very loud and intense. And this is reaching that threshold where now he's starting to get maybe a little bit of this traumatic reaction. And probably a similar internal sense of, holy crap, like how am I ever going to address everything that is in front of me? This seems insurmountable.
Robbie!
Okay, yeah. I was right that I wasn't going to remember everything from season 1, episode 1 of The Pit, but that was really fun reacting to it. I'm always surprised about what, you know, there is for me to react to, not as an MD, but as a psychologist. So hopefully that was interesting stuff for you. If you want me to continue with this, let me know. I think it would be fun to continue on episode 2 and onward. But yeah, let me know your thoughts down in the comments. If you're rewatching with me, let me know what you think now that you know the whole story and we're going back and watching episode 1 again. And thank you for watching. Bye.